Good afternoon, colleagues. I'm here today to present to you the ECC nurse algorithm for high sensitivity troponin. My name is Barbara McLean, and I am the Critical Care Program Specialist at Grady Hospital. Welcome. So, why are we going to high sensitivity troponin, and what is it anyway? On September 22nd at 8 a.m., Grady and all Emory facilities will be transitioning to high sensitivity troponin I assay. On that date, all new orders for troponin will always come back as high sensitivity troponin. Now, what does that mean to you? What it means to you is high sensitivity troponin is measured in nanograms per liter versus historic troponin, which was measured in nanograms per milliliter. That means it's 1,000 times greater. So, a typical troponin that was 0.01 will now be reported as 10. So don't have an MI. Just be aware that those numbers are 1,000 times greater. And the reason we're using high sensitivity troponin is twofold. Those two folds are really important. Number one, high sensitivity troponin is more precise and specific in the lower registered numbers because it used to be that our cut point was 0.04. Now those digital numbers will be remember, 1,000 times greater, and will allow us to rule patients out sooner for myocardial injury. That means that will influence ECC throughput. So quite important to remember, high sensitivity troponin is more precise at lower concentrations than standard TNI. So we'll rule those patients out earlier. Must-knows for high sensitivity troponin, there are different cut points for males and females. For males, cut point is less than 20 nanograms per liter, and for females, less than 15 nanograms per liter. Remember again that reported high sensitivity troponin will be 1,000 times higher than historic troponin. And that CK and CKMB should not be ordered to diagnose myocardial infarction. So the beauty of having the high sensitivity troponin is that will help us on the lower ends rule people out more quickly. Now, elevated high sensitivity troponin can occur with myocardial injury that is either acute or chronic. So providers, beware. When we take a look at the provider algorithm for high sensitivity troponin, you'll see that you have three different groups. The group on the left-hand side is the green group, and on the right hand is the red group. But remember, all patients will fall into evaluation if they have acute chest pain or if they have basic ischemic equivalence. So it seems like the chest pain is ischemic, and we perform an EKG. If that EKG presents with criteria for STEMI, that means ST segment elevation in at least 2 leads of a congruent lead group, you're done. Those patients meet STEMI criteria and they enter into the STEMI protocol. If your patients present with an EKG that has some ischemic changes or the chest pain appears ischemic, we will perform troponin. And that high sensitivity troponin, remember, starts with those cut points of less than 15 for females and less than 20 for males. And on that first run of troponin, the evaluation will be by your provider along with signs and symptoms and a heart score will evaluate whether or not that troponin is normal. So as we see high sensitivity troponin start to elevate, we will also look at the difference between first and second troponin draws, and perhaps we'll make a decision to have a third high sensitivity troponin at 3 hours. In the emergency department, each troponin will be accompanied by an EKG. 0 hours, 1 hour, and 3 hours will be the definitive times for drawing high sensitivity troponin. And as you see here, there's a relatively complex algorithm which looks both at sign and symptoms, heart score, the actual troponin level and then the delta troponin with each sequential draw. So this is your provider algorithm, but the nurse algorithm is much simpler. Indeed, if the patient has acute chest pain or an ischemic equivalent, we see them in triage, they get an EKG, and then we determine to do or not a 0 troponin level. Now that 0 means at the initiation, we're going to draw a troponin level. And remember, if patients have ST segment elevation in at least 2 leads of a congruent lead group, they are actually going into the STEMI protocol. Otherwise, they're going into the chest pain pathway for the emergency department. So presenting EKG has signs of ischemia or there's a suspicion for their ischemic pain. We're going to start with that 0-hour troponin. At the time of that EKG, 0-hour troponin. And by the way, that's pre-checked in your order set. Followed by a 1-hour troponin and an EKG, also pre-checked in your chest pain pathway. Now, if the troponin has changed or if there is a significant delta, the provider may determine that they want to follow that with a 3-hour troponin draw. That is not pre-checked, that is provider specific. So for all patients who meet ischemic criteria, not STEMI, but ischemic criteria, 0-hour troponin plus 1-hour troponin. These troponins, high sensitivity troponin, will replace historic troponin, and they cannot be replaced by point of care troponin. These are high sensitivity measures which will help us rule patients out at the lower register for myocardial injury and should ultimately improve ECC throughput. But must-knows, remember, men and women have different cut point values for abnormal troponins. Less than 15 for females, less than 20 for males. And in the troponin algorithm, we're going to be concerned at any troponin greater than 5, which is why we follow it with that second troponin to make sure that it's not increasing. Any change or a delta between the 0 and 1 or the 0, 1, and 3 of greater than 5 nanograms per liter indicates myocardial injury. High sensitivity troponin is reported in nanograms per liter 1,000 times greater than our historic troponin levels. Very important for us as bedside nurses to remember, report results immediately. Remember that this measure is more precise in the lower register and remind your providers that it's 1,000 times greater than our historic troponin levels. So, just the facts please. 8 a.m., September 22nd, converting to high sensitivity troponin I. Now your patient's old troponins will still be visible, but they will be in the old troponin measure. So always remember that when doing a comparative analysis. We as nurses, if the patient has signs and symptoms of ischemia or ischemic chest pain changes on their EKG, we measure at 0 hour and 1 hour. And that's automatic because it's pre-checked. And by the way, timing is everything. Measures are in nanograms per liter, which are 1,000 times the prior reported historic values. So don't panic when you see a troponin of 10 or 20 or 30. In prior history, we would have an MI if we saw that. But today, that's high sensitivity troponin. Remember, it helps us to identify myocardial injury, but not really differentiate acute versus chronic. That requires critical assessment. And it also helps us for risk stratification. And always remember, the reason we're doing it is non-injury states will be ruled out more rapidly and our vendor will no longer be producing the testing for non-high sensitivity or historic troponin eyes. Now, if you would like to know more about it, please feel free to click into this YouTube video from one of our eminent Emory cardiologists for further explanation of high sensitivity troponin. Thank you so much, and I'm always available for questions, and I hope to see you soon. This is Barbara McLean. Ta-ta for now.